Hello, everybody, and welcome to the ninth episode of Honest Discussions. I'm your host, Dr. Brandon Patterson, and today we're going to talk to Dr. Michael Rosenbloom from the Memory and Wellness Center at the University of Washington. Michael's a physician researcher that did a lot of work with one of the new Alzheimer's drugs that were just approved by the FDA. He worked on Lecanemab, and we talk all about the successes and side effects of these drugs. Now, there has been a fair amount of talk in the media about whether or not these drugs are effective, and I think that the honest discussion that Michael and I have will give you a foundation from which you can make your own decisions. For me personally, even if it's a small improvement, when it comes to losing your mind as a human being, I cannot think of anything more terrifying or more impactful in someone's life. But before we get to the show, if you could please like, share, subscribe, help us hit that 1,000 subscriber mark, help us get monetized so that the citizen science train can continue. Would really appreciate it. And on that note, on with the show.
Yeah, so it's the decision to go into dementia, clinical care and research. I think that's something that developed when I was a resident. So I did my residency at Mass General Brigham, and one of the more interesting patients for me was a patient with frontotemporal degeneration, which is a degenerative condition that affects the frontal temporal lobes, impacts a lot of things such as behavioral comportment and decision making. And I just was fascinated by a disease that could take that away, these abstract concepts of, our behavior and our decision-making capacity. It was just kind of, a disease that removed the self. And so I decided to go into the field of diseases that impact the self, Alzheimer's disease, frontotemporal degeneration, Lewy body dementia. And that kind of led me to pursuing a behavioral neurology fellowship with Bruce Miller at University of California, San Francisco, who kind of has been a world's expert in FTD and all things neurodegenerative. And from there, it was just such a wonderful experience. He and his group really opened my perspective towards these diseases, just the diagnosis and the different manifestations of these diseases, but also how to manage them. And then knowing that we're kind of on the frontier and that there's a lot of room and need for additional research and discoveries. And, it's been about 15 years since I did my fellowship with Bruce Miller, and now we have new drugs available for Alzheimer's disease. So it's kind of everything kind of originates from my experience at the UCSF Memory and Aging Center.
Well, one of the top neuroscience, centers in the world, really.
Yeah.
So you got very fortunate to be in such a great group of people working on that problem.
Yeah.
Well,
And
we're definitely going to get into the drug aspect of it, but what's the current numbers on how many people in the population can expect to get Alzheimer's right now, or at least in the US?
yeah, so right now, I mean, the data shows that, there's 6.7 million individuals with this disease in the country. And then we expect that, this is only going to continue to grow over time. There is literature that suggests, that the population could triple by 2050. And, I currently reside in the state of Washington, and there's about 120,000 people carrying this diagnosis. And so, as people live longer, we're going to have more individuals carrying this diagnosis of either mild cognitive impairment or Alzheimer's dementia.
There's is it rising? Like, do more, not as a percentage of people, but as a percentage of total, in the sense of, did more people get it now than in the 50s? Do we see an increase in Alzheimer's as a percentage of population?
Yeah, so I think there's a various factors. So yes, there are more patients who have the Alzheimer's diagnosis, and I think also because people are living longer, we're seeing the incidence and prevalence relatively increasing over time. I know when I started as a behavioral neurologist about 13 years ago when I was in practice, I think those numbers were just under 5 million per in terms of the prevalence of Alzheimer's throughout the country, and now that's grown almost 2 million. So clearly the numbers are increasing. I also believe that the perspective of the healthcare industry is much more sophisticated than it was 20, 30 years ago. Whereas in the past, we'd see somebody in their 70s with memory problems, we'd pat them on the back and say, hey, this is normal for your age. But now we know there is normal aging and the associated memory loss with that. And then there's Alzheimer's related memory loss, or, and other types of dementia affecting cognition. And we can distinguish those when we do a full evaluation in the clinic. So I think, the threshold for making the diagnosis is lower than it was before. And so as a result, we see an increase in incidence and prevalence.
So basically, because we've increased our ability to measure Alzheimer's, we can't really tell if, as a percentage of population, this is increasing, or that there were just lots of misdiagnoses in the past, and had we known, then we would see kind of a steady curve. It's just, we don't know right now.
Yeah, my suspicion that it's both factors are contributing. So, one is the fact that we're better at diagnosing, and number two is we have, what's called the silver tsunami, the baby boomer generation living longer, and as a result, when you have more people reaching their 70s, 80s, 90s, there is a greater risk for chronic incurable disease. And when you get to the 85 and greater population, 38 to 50% of that population has Alzheimer's disease. So I think it's both factors contributing.
That makes a lot of sense. So, do you know off the top of your head roughly, of the number that have diagnosed with Alzheimer's, how many of them have known genetic predispositions to having Alzheimer's? Because I think this is an important part of the whole scheme of what we know.
Yeah. Well, I would first say, Brandon, that my impression is that we only know the tip of the iceberg when it comes to the genetics of Alzheimer's disease. So, we know the most about the autosomal dominant mutations like presenilin-1, presenilin-2, the amyloid APP mutation. And, these are autosomal dominant mutations that are passed down from generations. The next generation has a 50% chance of inheriting that gene. And if you carry that gene, it's basically your destiny. You're going to develop Alzheimer's disease. And, that accounts for about 1% of Alzheimer's disease. So it's not,
a really small fraction. That's what I was curious about.
Yeah. Now, there are other genes. There's the ApoE4 genotype. We can have up to 2 copies of that. And so having an ApoE4 gene, and if you have 1 to 2 copies, you have an increased risk of developing Alzheimer's disease. And there's some literature that suggests you may get Alzheimer's earlier in life. So let's say if you're supposed to get it at 68, you may get it at age 60. And so if you check for ApoE4, we know that there's a greater risk. So there is a genetic factor that we can test for. The problem is that if you're an ApoE4 carrier, that's not your destiny. So you can be an E4 carrier and not get Alzheimer's disease, or you may not have E4 and you may end up getting Alzheimer's disease. I should also note that you can also be ApoE2, ApoE3. And these other factors do not increase your risk for dementia.
But on the flip side of that, there people that have ApoE4 mutations that actually then makes them more resilient to uh, Alzheimer's progression, that they actually resist it because of the mutations in ApoE4?
Yeah, so there is some literature. There is a literature of a paper that where they had somebody, and this is I've seen this article. It's been a while since I've read this, but there was a patient who had a mutation in an autosomal dominant gene. I think they were a presenilin mutation, and then they had a Christchurch mutation of ApoE4 that then protected them against developing Alzheimer's disease. And that's the only single case where the E4 mutation protected against the autosomal dominant mutation. I should also mention that ApoE2, if you're an E2 carrier, that will reduce your risk we know that's actually protective. So if you had a choice between being ApoE2, 3, or 4 positive, you'd want E2, but that's relatively rare in the population.
So basically, what I'm hearing from what you just said is that we are even, pardon me, even 30, 40 years into Alzheimer's research at the genetic level and the protein level. We are still far away from understanding the full determinants of Alzheimer's in general.
Yeah, this is and yeah, I agree with that statement. And this is how I know this is that I have plenty of patients who I see in clinic, and you'll see somebody who is at an age like 74, and then they'll tell me everyone in their family has developed Alzheimer's disease throughout the generations. Now they're developing it at an age that is appropriate, but there's some type of genetic factor that is causing everyone else in the family, in their 70s or whatever, to have Alzheimer's disease, but we don't know what that gene is. So, normally we would call this sporadic Alzheimer's disease, but I do believe, based on my clinical experience, that there are probably additional mutations that we just don't know about, or additional factors that may be responsible for, let's say, late onset Alzheimer's disease and increase that risk.
Well, I'm going to ask you about that, but maybe be good for you to really explain kind of what the current state of Alzheimer's research is. Like, what are the things that we're pretty confident about that we know are targets and or symptomology, and then what's kind of the newest things that we know about?
Yeah, well, Alzheimer's has always been a really challenging diagnosis to make. And I think, you talk to primary care doctors, they feel they don't have enough time to make the diagnosis. Sometimes they seem a bit wary to render an Alzheimer's diagnosis because of maybe there could be some emotional fallout and the stigma associated with it. And they may not have confidence in their ability to make the diagnosis either. There's also been this kind of nihilistic approach where any type of dementia is seen as incurable, and therefore you can't prescribe drugs, and therefore, what's the benefit of making a diagnosis? And I really feel that the research over the past several years has caused to see change in this area. So, right now, if I were to see a patient in my clinic, and I did all the usual workup. And when I do a workup, I always say, I'm going to gather different pieces of a puzzle to figure out what's going on with you. That involves taking a history, doing cognitive screening, checking laboratory studies, doing neuroimaging for structural abnormalities. And then if you have this resource, formal neuropsychological testing that involves at least 4 hours of cognitive batteries, where you can compare a patient's performance with other people, their age and their education. And that helps you answer the question, is this normal aging or something else? And where are the weaknesses and where are the strengths? And therefore, is it consistent with diagnosis X, Y, and Z? So there's a lot of different pieces of the puzzle that one has to gather. You have to have quite a bit of infrastructure at your respective institution to do this type of work. And now we now have the ability to do what we call biomarkers. So, in our clinic, let's say if I'm uncertain about the diagnosis after these studies are done, I can do a spinal tap. And in that spinal tap, I can send labs to look for proteins that would rule in or rule out Alzheimer's disease. And so this is a step towards a more biological approach to this condition. Of course, this is an invasive test and it takes time, and not a lot of patients look forward to a spinal tap, but it is much more objective. Yeah.
Yeah, but I mean, you have to do the same thing for multiple sclerosis
Yeah.
or other neurological diseases. I mean, if you want a diagnosis, what are the proteins that you look for in the screen? Like free tau proteins or free amyloid proteins?
Yeah. So I'm looking. So what one looks for is A beta 42, uh, p tau, well, 181 or phospho-tau, and t tau or total tau. So A beta 42 is essentially representative of the amyloid plaques, which are necessary but not sufficient for a diagnosis of Alzheimer's disease. And what happens in the brains of patients with Alzheimer's, you get these aggregates of amyloid plaques and these neurofibrillary tangles. And when you do a spinal tap, which is coming from the vantage point of the lower back, what is seen is counterintuitive. The A beta 42 levels go down. And the thinking behind that is that they're all being clustered into these amyloid plaques that are based in the brain parenchyma.
Oh, that I would have never thought that. You're right, it is
Yeah.
counterintuitive, but it's basically the brain soaking up the A beta 42 into the amyloid plaques.
Yeah.
So where it's actually needed lower in the spinal column, you're not getting that.
Yes, exactly. The other thing is you do see an elevation in phospho-tau or p-tau, which translates to those tangles in the brain. So those go up. And then in general, the total tau, the final marker, is just a non-specific marker of neurodegeneration. So that goes up too. So if I see a ratio where that suggests the A beta 42 is going down, the p tau is going up, and the t tau is going up, then that rules in, suggests, is consistent with Alzheimer's disease.
And when you look at the brain scans, what you're mostly looking for are the plaques, the amyloid plaques, and the tau tangles, right?
Well, it depends on the brain scan you're looking at. So in regular clinical practice, we're doing brain MRIs or CAT scans, and that's a structural scan that essentially can help you see if there are, strokes or microvascular disease. You can also see evidence for brain atrophy in Alzheimer's disease. We're specifically looking for hippocampal atrophy, which is the organ that is responsible for the formation and retrieval of new memories, but you don't see the plaques on an MRI. So there is a certain special type of scan known as an amyloid PET scan, and this involves giving an injection of a ligand that binds specifically to the amyloid plaques. Of course, this is not something that is reimbursable yet for routine clinical care, so it will be an out-of-pocket expense of at least $10,000 for the patient. But that's the only way to see plaques on an image right now.
That is unbelievable to me. It really is. 10,000. I mean, if you have healthcare insurance, you would think that that would be something that would be covered, from the simple fact that it is going to save a lot more money in the future, potentially, because you're diagnosing it correctly much earlier.
Well, I can give you the history of this. So, before we had any drugs that were disease modifying for Alzheimer's disease, we knew that the amyloid PET scans did facilitate an early diagnosis, and CMS, which is kind of the Medicare essentially, ruled that there was no evidence that the doing an amyloid scan impacts outcomes, clinical outcomes at all in patients. And people said, well, we need a disease modifying drug, and then that will be the factor. And so there were some studies that came out. One was called the IDEAS study, and right now there's another one called the New IDEAS, looking at whether just doing the amyloid PET scan, does that impact healthcare utilization and medical decision making? And at least the literature so far shows that, 2/3 of the time it's going to affect physician decision making, but may not, at least within a year's time, affect healthcare utilization, ER visits and hospitalizations. However, we're now at the point where we do have drugs that have been shown in clinical trials to slow the disease down. And so this may be a new time to reinvestigate whether or not this should be covered. And I know that Medicare has actually stated that they will remove the amyloid PET scan as just, clinical evidence development, meaning that the only way it would be covered is if you're in a clinical trial or investigation. And they're likely going to have their local chapters make decisions about whether or not it will be covered, because it's essentially going to be needed when you prescribe drugs like Lecanemab or aducanumab to rule in the diagnosis. And then there are other drugs like donanemab, which have been used in a manner that suggests an induction type of approach. That is, you give the treatment for a period of time, let's say 12 months, and then you look at the amyloid plaques in the brain, you compare it to their baseline. If the plaques have disappeared, you stop the therapy. And so we may need amyloid scans to not only rule in patients at the beginning, at the baseline, but also to see if there's any impact or efficacy of the drugs that we're prescribing.
Great answer. Let me give you a setup question to get into the new drugs. And that's, why has it been so difficult to develop pharmacology for Alzheimer's?
Yeah, so a lot of the pharmacology that has been developed for this condition has been based on the amyloid hypothesis, which this was something that was developed decades ago, and it states that the first changes that occur in Alzheimer's disease involve this abnormal cleavage of this transmembrane protein, the amyloid precursor protein. And then you have the formation of these A beta oligomers and polymers and eventually the plaques. And then that causes downstream effects on tau, which is a protein that makes up the cytoskeleton of the cell. And then this tau gets phosphorylated, forms these neurofibrillary tangles, and then you get the plaques and tangles, and then that results in inflammation, oxidative reactive species, neuronal cell death. And so, a lot of the therapies have been developed to try and counteract amyloid. And so, years ago, there was a vaccine that was developed that resulted in encephalitis. And so as a result, that was, canned. They stopped pursuing that. And then, for the past, decade or more, there have been a variety of anti-amyloid drugs that have been developed. These are monoclonal antibodies that are targeting the amyloid plaque. One was known as bapineuzumab, solanezumab. There are also other drugs that kind of prevent the pathway of the amyloid precursor protein being cleaved by this enzyme known as gamma secretase. And so everything was amyloid focused. And at the end of the day, these trials found that the drugs, while in some cases they did remove amyloid from the brain, they had no effect on cognitive and functional outcomes. They were useless, essentially. And in fact, there were some studies that suggested brain atrophy increased while receiving these drugs. And so, you'll see, just before, the data on aducanumab and lecanemab came out, there have been editorials by very prominent Alzheimer's researchers saying, what, we should probably stop looking at the amyloid pathway and pursue other avenues of treatment. And so there have been other kind of theories. So for instance, there's the theory that Alzheimer's is a type 3 diabetes of the brain. And so, there's been thoughts about intranasal insulin, and there have been studies on this, or that there's a metabolic disarray in the brain of patients with Alzheimer's disease. And so there's, and then, you have other approaches that affect the downstream molecules. So there have been drugs that have been developed to block tau phosphorylation and then aggregation in the brain. or anti-inflammatories for the downstream of, effects. There's been thoughts that, well, should patients be on aspirin, long term because it's an anti-inflammatory, and that's been found to not be efficacious. The other thing that makes the study of Alzheimer's disease challenging is that usually it takes about a year, maybe a year and a half, to see some type of decline in cognition or function in Alzheimer's disease. So it's not like, treating an infectious disease where you can kind of get to your primary outcome measure in 2 weeks. You need to have long, expensive clinical trials that go on for 18 months to really, distinguish between and have the power to detect outcomes between placebo and the treatment groups.
Well, is it fair to say that uh, you know we can visualize certain aspects of Alzheimer's, like the tangles and plaques, and that some people can actually have a lot of these and show fairly mild, if any, symptoms. Meanwhile, there are other populations of Alzheimer's patients that have relatively low tangles, phospho-tau, and plaques, yet have much more advanced symptoms of Alzheimer's.
Yeah, so you bring up another point that makes the study of this disease that much more complicated. So, Jakob Stern, who is a very well-established neuroscientist, dementia researcher based in New York, has come up with the idea about cognitive reserve. So, cognitive reserve has to do with, essentially how dense our brain networks are because of our environment and or genetics. And so, somebody who has a high reading level, who has a graduate degree, probably has more cognitive reserve than somebody who, dropped out of high school, and, did not have the same, nourishment throughout life. And so, it may take less Alzheimer's pathology to elicit clinical symptoms of the disease in somebody who has less cognitive reserve compared to someone who has more cognitive reserve. So, somebody who has great cognitive reserve, you may see their brain riddled with pathology before they present with symptoms, as compared to someone who has less cognitive reserve. It may take a little bit of pathology for them to eventually decompensate and have clinical symptoms. One should keep in mind that the amyloid plaques and tanglers are building up in the brain decades before anyone presents to the doctor with memory loss.
Is it also, couldn't it also, that's one explanation. But another, and it, because Alzheimer's appears to be this multi-dimensional disease that we still don't know all of the nodes that connect the Alzheimer's network. Couldn't it also be that you're getting some type of insult, perhaps environmental insult, that you're going along fine and yeah, you're getting tangles and whatnot, but you come across environmental insults that could also be the trigger, or an additional trigger to what's going on, making it worse?
Yeah, that's a good point. And I think when you use that term environmental, I kind of see that as a very broad
Very
category. So,
broad.
I'll give you an example. You have somebody who's kind of going along, quite well, living a normal life, biking every day. They're in their, early 70s, and then they have to have a hip replacement. They go in, they have a hip replacement, and then when they're in the hospital, there's delirium, and they have delirium for several days, and then they eventually go through rehab. They get home, and then family starts to notice, well, you know what, Dad's seems kind of different. He's not as sharp as he used to. He's not going out on his bike rides. And so that's an example of how an environment or mental factor, delirium can sometimes hasten that progression towards clinical disease.
You could imagine stress as well being a major player in how quickly something like Alzheimer's onsets. If you're below the poverty line, if you're under constant stress to pay your bills just to keep your head above water, I could imagine that kind of stress only amplifies the onset of symptoms.
Yeah, I mean, I can't tell you how many of my patients who come to me and told me that their condition developed or worsened in the setting of the COVID pandemic. And, there was stress associated with becoming ill and getting the upper respiratory infection or lower respiratory infection if it's complicated, or being isolated from family members and being depressed as a result of that. I think stress certainly is a factor. And, at our center, when we talk to patients who are either early stage or, their normal aging, we talk about, strategies to limit stress because it is a factor that needs to be considered.
Just so you know, the fact that you mentioned COVID, I'll have to chop out this whole little section
Mm,
and it'll be in the video I'll post on Rumble because they don't censor it. But
mhm.
anytime you mention that on a YouTube video, it's they just demonetize or they just remove the video from the platform.
Oh, really?
Yeah,
Mm,
it's crazy. I had it
mm,
happen. I was talking to somebody about hyperinflation and
mhm.
mentioned COVID, and the video was pulled off of YouTube.
Interesting. Okay.
So, not that it matters because I'll just put a little block in and say, you know, if you'd like to see the full discussion, go to, here it is. But so then that was a great description. Now, I guess we should talk about what we're here to talk about, which is how do you say the name of the drug again?
Uh, Lecanemab or Leqembi,
Lecanemab.
that's the trade name.
Okay. So maybe you could tell me what it is. What do you have a mechanism for how it works? And then, what the studies showed, what kind of prophylaxis and or prevention does it provide?
Yeah, sure. So first of all, lecanemab is a monoclonal antibody that binds specifically to the oligomeric form of amyloid. So this is when
So
it
this
is,
is not a traditional drug, just so everybody knows. Like monoclonal antibodies are called drugs, but they're actually part of the immune system itself.
yeah, so it will bind specifically to, what we call soluble amyloid. That means you can kind of dissolve it, whereas the plaques are the insoluble amyloid. So it's not getting to the plaques, it's getting to these smaller clusters of the protein. And what it does is it takes them out of the brain. And it is a drug that was developed basically to slow the disease progression of Alzheimer's disease. And the way we test for that in clinical trials is we have specific measures of cognition and specific measures of function. And a lot of these scales, like the clinical dementia rating scale, combine cognition and function. And so this often serves as the primary outcome measure in these clinical trials. And so in this study, they looked for patients who had early evidence for an Alzheimer's process. So number one is they enrolled patients with mild cognitive impairment, which by definition means that these patients have symptoms of memory problems, objective evidence on cognitive testing of memory problems, but they can still go about their instrumental activities of daily living. So they can drive, cook, grocery shop, things like that. And then also they had patients with mild Alzheimer's dementia. So these are patients that, who had some compromise of those activities, but still, were able to make informed decisions and, we're not in, assisted living or nursing homes or anything like that. So at the earliest stages, and this is something that can be teased out by giving baseline cognitive tests to make sure that patients qualify. The other important step is that patients underwent, either a spinal tap or amyloid imaging to confirm that they had the amyloid Alzheimer's pathology in the brain. And only if you had that pathology were you able to get into the clinical trial.
Okay. So for sure, the person was in the process of displaying or clearly displaying Alzheimer's symptoms, plus had some level of amyloid plaques or elevated levels of A beta 42 clusters.
Right, right.
Okay.
And then, so, there were about, I think, just under 1,700 patients in the trial.
Wow, that's a big
And
trial.
yeah, so, we had large numbers of patients. And so, half of those patients received placebo, the other half received the lecanemab. And the duration of the trial was roughly 18 months. And so, as I said before, you need to study patients long enough to ensure that they have the chance to actually decline, so that you can look at that outcome measure. And so what was found was those patients who received lecanemab for the 18 months, their decline on measures of cognition and function was reduced by 27% compared to placebo.
Well,
And so that was the primary outcome measure, and that was met. And the exciting part of that is that, this is the first trial where there was no debate whether or not the primary outcome measure was met. And so that was what was exciting. And at the same time, this drug profoundly reduced the amyloid in the brain in patients who were amyloid positive. And it was so significant in some cases, the amyloid in the brain was not detectable.
that's really interesting that while treatment alone of amyloid prior, or like, because you already said you could remove it, and there were other drugs that removed it and you didn't see progression, or that you did see progression. Yet this is kind of working along the same lines, and yet it's slowing down progression more than placebo, which is, huge. So, because for people that have Alzheimer's, any amount of reduction is worth it. You don't have other options. So,
Yeah.
do you have any idea why this one is different?
Yeah, so that's a great question, and I'll give you my best guess. So, a lot of those drugs from the past, uh, they there's some speculation that they were not dosed long enough. In addition, they were not dosed high enough, and then not all those trials used the biomarkers to rule in Alzheimer's disease at the beginning. So I think it's a combination of factors. Now, there is this um, side effect of these drugs known as ARIA, or amyloid-related imaging abnormalities. And there's two types. One is ARIA-E, or edema, where you get brain swelling. And another one is ARIA-H, or where you get these microhemorrhages. They're asymptomatic most of the time, but you can detect them with special sequences on MRI. And they found in those early trials that the risk of this was present, but fairly lower than a drug like lecanemab and aducanumab, which was the drug that preceded lecanemab. But now, over time, there's this theory that if you dose high enough and frequently enough and long enough, then you're more likely to get efficacy, but also your risk of the ARIA is increased. And so the effectiveness of the drug, as well as the risk for side effects, go hand in hand. So if you see the side effect, you know that you hit your target tissue, and that maybe that tells you that the drug is doing its job. And so the risk for ARIA in the lecanemab trial, if you include both the ARIA-E and H, it was about, together, it was just over 21%. And so, that's a relatively higher than the earlier trials with these other drugs that were not efficacious. So that's my best guess, is that you give the drug at a high enough dose, and as frequently as you would with lecanemab. So this is being given at 10 mg per kg, and it's given also every 2 weeks rather than monthly. So that's a relatively aggressive dose. And as a result, it met its primary outcome measure, and then also it has this relatively higher risk of ARIA-E and H.
And how bad are those? I'm actually not familiar with either of those conditions. How bad is that in comparison to losing your mind to Alzheimer's?
Yeah, I mean, I would, I would say this is that when you hear about brain swelling or microhemorrhages, it sounds worse than it actually is. Only a small percentage of patients were symptomatic. So, close to 80% were asymptomatic, and this was found incidentally on the screening MRIs. But, there were three cases of mortality that were thought to be related to the drug. Of course, this is out of, close to 1,700 patients, so that risk is very, very low. But it was believed that those patients who were ApoE4, E4, who had carried two copies of that genotype, those were the individuals who were at the greater risk for the malignant manifestations of ARIA-E and H. And so, as we move forward with using this drug in the clinical setting, one must, exercise a great deal of caution. And so there, are protocols, at least at our site, and, probably all institutions that are given this drug to maintain safety.
Ultimately, you're developing a panel probably to look for things that if you have this particular mutation, you maybe are not a good candidate for this drug because of increased risk of hemorrhaging. Is that a good
Yeah, so
summary?
there was a great paper that was put out by Jeff Cummings and colleagues earlier this year about the appropriate use criteria for lecanemab. And this is a really great paper that kind of lays everything out, what you should look for to include a patient for lecanemab, and what clinical factors should exclude a patient. And so we can look for certain factors on an MRI, evidence for stroke or some of these microhemorrhages that may predispose them to having further bleeds. And then the other thing that we've never done in the past, but now because it affects medical decision making, it's advocating. This paper was advocating for checking an ApoE4 genotype, and it didn't really make much of a difference in terms of medical decision making if you tested it in patients, and so insurance never covered ApoE4. But if it can tell you, well, if you test positive for E4, your risk for ARIA is, let's say, threefold compared to someone who is negative. That's meaningful information for somebody who is trying to weigh risk versus benefit of receiving the treatment.
And for the cost of a DNA test, which, I mean, considering how cheap sequencing technology is these days, that should be pennies in reality.
Yeah.
But
Yeah,
I'm sure
although
it costs $100 to $1,000.
yeah, the only thing is that it's recommended that they have this tested by, let's say, a CLIA approved laboratory, which will probably bump up cost for that. But your point's well taken. Yeah, it's much easier to get genetic testing these days.
Stepping aside from the Alzheimer's aspect of it for just a second, but focusing on the study, roughly how much did that study cost for 1,700 people?
God,
Ballpark.
I don't have but this would be millions of dollars, an extremely costly, try. I mean, that's why a lot of pharmaceutical companies have backed out of the Alzheimer's industry, because the drugs were failing, and also to do a trial like that, it was expensive. It could put you into bankruptcy.
We can get to the pharmaceutical companies because they have their own issues. But from your perspective, the person actually doing the real work, what could we possibly do to start reducing the costs of these studies? One thing right off the top of my head, you just brought up, has to be sequenced by an approved lab for some technology that I'm sure there's a 12-year-old kid in their basement right now sequencing DNA somewhere. I mean, this is the level that it's gotten to. The technology is so cheap, yet it has to go through this regulatory body that then tax on all of this extra money. So that's one aspect of making studies expensive. But how can we even begin to start combating the expenses of the study? Because we actually need more studies than we have.
Yeah. Well, I feel like when you asked me about different developments in Alzheimer's, one thing I didn't get a chance to talk about was the development of blood biomarkers, which blood test is extremely cheap, and the studies that I mentioned to rule in Alzheimer's disease, doing a spinal tap, which is invasive, and then the amyloid PET scan I told you cost
And
uh,
grand.
above 10 grand. That really, when you're studying, 1,700 patients, that all adds up. But if you had a blood biomarker, you can reduce the cost of a trial significantly. In addition, the blood biomarker might be something that a primary care doctor may feel confident in checking. And there are various companies around the country that are working on blood biomarkers, and the data is really exciting, showing that the sensitivity and specificity often parallels that is found with the amyloid PET scan or with the CSF study. So I believe in the future we will have a blood biomarker for Alzheimer's disease.
But in a general sense, as somebody who's doing clinical studies, how can we start? Do you have any ideas on how we can start increasing the number of studies and decreasing the cost? And I mean, I just pointed one out, which would be to stop some of this regulatory nonsense that is only in place so that certain people make money and certain people don't.
Yeah. Well, I think another thing is just the duration of the trials. That's another thing is that I need to follow patients for 18 months, and there are ways to enrich your population and be able to find those patients who are more at risk for declining in a shorter period of time. Like for instance, the Lecanemab study, which is another drug that probably will be approved by FDA in the future, that acts similarly to lecanemab. This trial I thought was brilliantly designed, where they looked at patients who underwent tau imaging, and that showed how much tau was present in the brain. And the theory is that if you have more tau in the brain, you're more likely to decline. Therefore, during the period of the trial, you may be able to capture this. So that's another
That's
approach
it
where
is
you
very
enrich your
clever.
population.
Maybe you should explain for anybody who's not of the scientific ilk watching this, like what are the earliest of early warning signs for Alzheimer's that either children can be watching for and their parents, or old farts like me can actually be looking for inside of ourselves.
Yeah, so I would say that you think about what involves the greatest amount of, let's say, brain activity to perform, and then you will see some of the early symptoms come out. So, in my patients who are still working, it may take them longer to do a job that they've been expert at for decades. They may be making more mistakes. A supervisor may approach them and tell them that they're kind of not producing, they're not as productive as they were in the past, and that's often a red flag for me. Also, early on, patients may struggle with technology. So, we're surrounded by technology these days. I mean, look, we're talking virtually right now.
Right.
But having more difficulty, operating a smartphone or their computer, forgetting their passwords, being taken advantage of by scammers online, that's often an early symptom, or going to the mall and not finding their car repeatedly, not once in a while, but frequently. And then later on, and I feel like, those other things, those are the symptoms that evolve first. But, often in my clinic, I hear about patients, forgetting conversations or repeating themselves, losing things routinely around the house, getting lost in familiar areas. Those are a lot of the early symptoms that I hear about in my clinic.
So I guess to kind of wrap this up a little bit, any types of cognitive decline are like, or could be an indicator of some type of dementia, whether it be Alzheimer's or Lewy body dementia or whatever. And that if you really had any notice other than I can't, I set my keys down in the house and I can't find them. I mean, you'd suffer that when you're 20 years old. You don't need to
Yeah. I
have
mean, I think
dementia.
it's also important for your viewers to keep in mind that it's we do have a decline in our cognition as we get older. That's normal, and I don't want everyone freaking out after hearing this. So, normal aging, the patients may have this issue. I hear this all the time. I walk into a room and I forgot why I went into the room in the first place. That's a really common symptom I hear in the normal aging. Or I was having this conversation, I couldn't figure out the right word to say, and it was at the top of my tongue, tip of my tongue. Those types of things occur with aging. I mean, we got to keep in mind as by the time we reach our 30s, we start to lose neurons. It's a depressing fact, but it's a fact, nonetheless.
I've read studies that certainly increasing your mental output uh, is a strong protectant against aging. Do you agree with that? That being mentally active and being as mentally active actually as possible is
Yeah,
a strong deterrent for.
I do. I do believe that, and I actually tell my wife that I'm going to retire when I drop dead. I'm not retiring until I have to because I need to keep my mind active, and I feel that if I were to no longer have that intellectual stimulation, that probably the mind is like a muscle, and if you don't exercise it, then it will degenerate, and our networks are much more fragile as we get older. So there is literature, about the importance of staying physically active, and I will emphasize that the physical activity is the most important thing you can do. Generally, I would say 30 minutes of aerobic activity 5 times a week, or 150 minutes a week. And we know that that has the most profound effects, specifically for executive function, but also cognitive stimulation is important. And that can take the form of not just crossword puzzles, but reading, writing, playing an instrument, doing something new. For me, I try to, induce some type of variety in my life rather than just, operate reflexively because that doesn't really stimulate the brain.
No,
And
I mean,
yeah,
one of the biggest, I mean, there are plenty of studies in neuroscience showing that neuroplasticity is increased by is increased by novel stimulation. So, and not just in rats and mice that get put in different cages, in humans.
yeah.
So, forcing yourself to get out of your quote unquote comfort zone and experience new things, no matter what it is, can be a very strong uh, inducer of neuroplasticity and increased synaptic formation.
I agree. I actually just want to paraphrase. There's this great researcher at Harvard, Alvaro Pascual-Leon, who uses transcranial magnetic stimulation for a variety of neurological disorders, and he has this wonderful quote that neuroplasticity is the way that we overcome the limitations of our genetics. And I think that's beautiful that there's something we can do to alter our fate and help ourselves either become more resistant against these diseases or self-actualize as well. And I think that's everyone needs to be an active protagonist in their own, cognitive health.
1,000% agree. I have two more questions. One, have there been any studies using TMS? Because I know from TMS studies on PTSD specifically that TMS can have dramatic effects on PTSD, and concussions.
Yeah.
Has there been any work done with Alzheimer's?
Yeah, there are about 30 small studies looking at TMS and Alzheimer's disease, and that actually is an area of interest for me because, again, we are looking at drugs that slow the disease process in Alzheimer's disease, but how do we help patients regain their function? And that hasn't been talked about as much. And I don't know if TMS is the answer, but it is at least a way to encourage neuroplasticity in vivo and see if it has an outcome that is favorable. So this is a really a cutting edge idea in this field, and there are various groups, including ours, that are exploring this approach.
That's awesome, because I personally believe that TMS is one of the underutilized and understudied and uh, under poorly understood as a whole, because for so long we've looked at the brain as just a machine, and the neurons rule everything, and everything is run by how the neurons fire. And there's data coming out now constantly about the electric fields in the brain, and how the electric fields control things, and how the electric fields are part of moving the information of the memories through the brain. It's not just the neurons. And there's even a couple studies. I had somebody on that his work was showing that the electric fields were actually the information carriers, and that the synapses in the neurons were part of the mechanical process of memory imprinting, but the actual memory information that got imprinted is carried by the electric fields in the brain. Really interesting.
Yeah, I mean, I think I completely agree. And one of the forefathers of behavioral neurology, Norman Geschwind, who was a Harvard educator and professor, came up with the idea of large-scale brain networks being responsible for many of the complex functions like language and memory and executive function. And that's essentially what the brain is. It's the most complicated organ. And you have these large-scale brain networks that maybe could be imposed upon when you apply TMS. And language is just, when I name an object like this pen, it's not one area of the brain that's doing that. It's more
No, it's a whole
complex than just
network.
Broca's area. You're using many different brain areas that are connected by networks. And so if you can have an impact on those networks, then you can potentially enhance cognitive function.
Couldn't agree more. So here's my final question. It's kind of fun, but maybe, and might be funny, but maybe not. Have you considered, considering that they've shown incredible neuroplasticity and neural stimulation and even neural growth in response to psychedelics, in particular psilocin and psilocybin? Has anybody started to look at that to see if perhaps these drugs that are very potent stimulators of neuronal growth and plasticity could have any effect on delaying the onset of Alzheimer's?
Yeah, so that has not, to my knowledge, been studied. To my knowledge, the use of psychedelics there's a lot of literature supporting their role in PTSD, and some real profound effects. And the body keeps the score. That's a great book that kind of describes those effects. And also, I've heard people describe the experience of being on psychedelics. It's kind of like it forces you to experience certain things, like you have the wonder of experiencing them for the first time, which is kind of kind of very interesting. I realized when I just moved to Seattle, and I had that feeling. I hadn't had it for many years, and it was wonderful. So you can imagine, how people might be drawn to something like that. But I would have to think about the role of this drug in neurodegenerative diseases. My perspective is I'm much more open-minded toward using them than I was in the past, because the whole idea of the bad trip is I think that's been overblown.
Well,
And
a bad trip has nothing to do. It's set and setting.
yeah,
If you are going to take a drug as powerful as a psychedelic and put yourself in a poor position around poor people when you do it, chances are you're going to have a really bad time.
yeah,
That's the most likely outcome. But done in a clinical setting and or a uh, for lack of a better term, a shamanistic setting, but I could just say, a couple of good friends that are already experienced, you could actually make it that you have a 99% chance of having a very positive experience. And being experienced myself, I will say this, that there are times that an idea or something will be put in front of you that you don't want to deal with. But the only way to move through it is to move with it. And a lot of people that use psychedelics will always tell you, like, don't try and fight it. That's when the bad trip starts. No,
yeah,
you have to go with it. And if you're having to deal with some problem during that state, you're probably actually in one of the best mental spaces you could possibly be to deal with it. And when you think about it and move through it, you come out the other side, you're like, oh, I'm a new person. This is amazing. But I'm just wondering if, even as a preventative, as a prophylactic preventative, if it does cause some, well, it does cause neuro, pardon me, does cause uh, neuronal growth, causes synaptic strength improvements, does all of these good things for neurons. I wonder if early on, using it in a cyclical manner so that you get this dose of new neuronal growth and new synaptic connections wouldn't have some type of an effect. It's just a thought off the top of my head.
yeah. I mean, I'll put it this way: I don't have enough data to say that I would recommend doing that. I also would say that, these preventative studies are extremely challenging because, these patients may take years and years to develop the disease.
And how do you know that they
Yeah,
were going to develop? They weren't going to develop at that rate anyways.
right.
Yeah, well, might still be something good to consider in an animal model, though, where
Sure.
you could actually look at it on a sped up time scale, even
Yeah.
though the animal models we have are still not the best, but they're serviceable.
Yeah, I think an animal model would be a good place to start.
Well, Michael, thank you so much. I learned a lot today. I really appreciated your time. Is there do you have a link or anything where people can donate to your studies?
Yeah, so I am at the Memory and Brain Wellness Center at the University of Washington. And so this type of work that we talk about with TMS, it very much depends on philanthropic funding. So I can certainly send that link to you, Randon, but verbally, it's the Memory and Brain Wellness Center at University of Washington.
All right. Well, thanks again. And next time you have something interesting to talk about, please get in touch with me. It's great talking to you.
Great. Thanks for having me on. Nice,
All
nice
right.
talking with you.